Good day, all, and welcome to the Teledigm Pulse podcast, your Rural Health Matters resource. Hear from your colleagues and industry experts on rural health issues and innovative care models that make a difference for rural hospitals, providers, and communities.
Well, hello and welcome to the Teledigm Pulse. We have a little bit of a different podcast today. My co-host, Shane Fleming, is not with us today, but I have a stand-in for him. And then we have another really great guest. So I think we'll have an exciting conversation today. Looking forward to it. So with me today, I have Dr. Brian Bossard, who is CEO and president of Teledigm Health. He is here with us today. And also I have Dave Reese from Madonna. And so Dr. Bossard, you want to introduce yourself and tell the audience a little bit about yourself, and then Dave, I'll have you do the same.
Yeah, thank you. I am an internal medicine physician, have been practicing locally for almost 40 years. Really focused on hospital medicine for 30 of those years after working in a traditional internal medicine environment for about a decade. And during that time, have expanded my interest to include care in rural communities and have started hospital medicine practices in rural communities throughout Nebraska. I've also worked in a consultative role with hospital medicine practices around the country, either practices that are fledgling and new and starting, or hospital medicine practices that have had some difficulties. So a lot of time in that area. And then the last 10 or 12 years have been applying that to the virtual world. So creating outreach through virtual applications for hospital medicine and many other clinical services. Thanks for having me.
Yep. And Dave, we've known you for a long time. This is a little bit newer role for you, but why don't you go ahead and tell the audience a little bit about yourself and what you've been up to?
That sounds great. Thanks, Andy. I'm David Reese. I have about 30 years of experience in healthcare. Born and raised right here in Lincoln, Nebraska, but spent about majority of my career, 27, 28 years at Bryan Medical Center here in Lincoln in an administrative role, various responsibilities from facilities, physician services, ancillary services, you name it. Had a lot of experience with physician relationships, though, and partnerships in development of cancer centers and joint ventures and the like. In addition to that, just recently, I moved over to Madonna Rehab Hospital, which has two sites, one in Lincoln and one in Omaha. That's post-acute care. In Lincoln and Omaha, they both have acute rehab as well as LTACs, but also in Lincoln, they also have a long-term care resident care center and a ventilator assist unit as well. And I've been there, it'll be a year this July as their chief administrative officer, and really enjoying that role and getting to see the difference between the acute care side and now the post-acute side and how they intermingle and the challenges that are different between both of them.
Mm-hmm.
Some of the positives of each and the negatives of each. And so it's been fascinating going through that process and get a chance to work with Dr. Bossard and Teledigm here in the group. And plus knowing that I'm a better golfer than Dr. Bossard is also a nice knowledge base as well.
You and the other 8 billion people on the planet.
Exactly. Well, 8 billion minus one, because
Okay.
I think you're probably still better than me.
I'd have to say minus one on because he just beat me the other day. So.
All right. Well, long-term care, post-acute, has its own unique set of challenges. So let's just have a conversation about, some of those unique challenges to long-term care, post-acute settings, and how we've been able to kind of come in and help address some of those. So just kind of open that up and let's talk about that.
Well, from the brief period of being a year at Madonna, seeing kind of the difference between acute and post-acute, some of the challenges that I've noticed is just one of them, the biggest one that Teledigm has really helped is just access to physician services.
Mm-hmm.
Especially when you're a post-acute rehab center that's not attached to a hospital. that's independent, does great work. But it's sometimes at times difficult getting those physician services because the physicians in the community are already busy with the acute care side.
Yeah.
And you need those services to keep patients where they're at. So working with your team and Teledyne, it has been invaluable getting those services through the telehealth process to be able to have access to some of those services and subspecialists that without that, I don't know if we would have them. And
Yeah.
then that leads to other issues going down the path. So right out of the gate, that would be the number one thing I could see when I first started there is some of the barriers right away. There's many others, but that's one of the first ones that I see.
Geography, it's interesting. As I thought about telemedicine years ago, we knew that we could create services in distant locations. That was something that we knew that virtual applications will help us do. And we needed to make sure that we would have strong connectivity and reliability, and we worked hard to create that foundation so that that can happen really anywhere.
Mm-hmm.
But the piece that I didn't really recognize early on was we also can create access to providers who aren't local. So building a team of really strong specialists and hospitalists or other provider teams is different with telemedicine when you can bring in a decentralized model of care.
Exactly.
And you can bring in great physicians and great providers from around the country who are part of your team. So geography really does go away in terms of a limitation or a barrier, and you can create access to great specialists through this model and also access to locations that otherwise might be too remote.
Yeah. So, I know one of the things we talked about before we started here was, the margins in the post-acute world are kind of starting to shrink up. And so how does telemedicine, help you address that issue and still provide great patient care?
So, Andy, I think that's so true. I think across the board in hospital care and healthcare in general, the margins are shrinking.
Mm-hmm.
But the switch over, the margins are even tighter on the post-acute versus the acute care side. Because on the post-acute, they don't have the surgeries, they don't have the radiology, they don't have some of those other services that you can make up margin on versus on the other side. So you're starting off already in a more challenging standpoint. How telemedicine and providers through telehealth works and how it helps is especially in evenings and weekends. You have your set physicians, the hospitalists, or your physiatrists that are there during the days, weekdays or weekend days, and providing care and great care, which we have at Madonna. But then in addition to that, you have to have the ability to have time off to be with family, quality of time, and you don't have the bandwidth to hire 10 physicians,
Right.
because that's costly as well. And so by having the impact that Teledyne has on Madonna is that after hours, weekend after hours, connecting with you guys to provide that physician oversight so the docs can go home and have a family life, be able to get bed, be able to get rested and have that balance in life. It helps us from a cost structure because it's not as costly to go with Teledyne than would be to hire another doc. In addition to that, by not having the doc but using Teledyne, it helps us to have the physician oversight, so we reduce the amount of return to acute cares.
Mm-hmm.
So patients aren't having to go back to the acute care setting, which then mucks up the acute care side in that process because there's lack of beds on the acute care side these days. Two, not great patient care overall because a lot of these patients are fragile and dealing with other issues. And third, reimbursement, because either the acute care side gets dinged because of a readmission, or the post-acute care side gets dinged because they were transferred too fast back to the acute care side. So it's all around, it's a win from that perspective, from reimbursement to quality of care to cost overall.
Yep.
We discovered in working with Madonna that a lot of our priorities fit perfectly with an LTAC. As we built our hospitalist service to meet the needs of rural communities, our single priority was to help those rural communities keep patients local, to help them avoid transfer of patients who want to stay local and who can be cared for locally. So our model was built to succeed in that area. The second main priority for us is to satisfy the clinical staff that we work with, the physicians, the medical staff, the nursing staff, and the ancillary staff. And so building that into Madonna's incredibly skilled team was really comfortable for us, and our priorities didn't have to change at all. We were able to integrate with what Madonna wanted to see happen. And ultimately, our goals are completely aligned. We want to take great care of patients. We know that there are times when patients need the skilled care that's offered in emergency rooms and in an acute care facility or an ICU in the hospital, but many times that's not the case, and we want to help identify those cases that can remain local. So our model really fit well with Madonna, and I think it's, from day one, it's been pretty clear it's been a great partnership.
Yeah, and I think, one of the things that's always struck me about Madonna, even before I worked here, was the quality of the care provided in Madonna. The reputation there is pretty incredible. And let's talk a little bit about telemedicine quality and how that's been working out.
So the quality has been outstanding. In fact, we just changed up probably in the last 3 months, where our physiatrists were taking calls at night. And we only have limited numbers. And so we switched it up to go to Teledigm to provide those services at night. Mainly medical calls was what they were getting.
Yeah.
And talking to our physicians on how it was going just recently, they talk so highly of Teledigm and the quality of care that the nurses say they provide when they do get calls, timeliness, satisfaction with the feedback they're getting and getting the help. And the physicians have had no complaints whatsoever. And we've been using Teledigm for a number of years on the LTAC side with hospitalists, and the same thing. Haven't heard any complaints whatsoever. So from a quality care, follow through, documentation of notes, it's just been superb. And I tie in one other thing that Dr. Bosser said earlier too, is in healthcare, the way things are going, I think all of us are feeling it, is with reimbursement continues to be ratcheted down. The uncertainty of government programs and what's going on there with Medicaid and Medicare. Where's all this going? And the baby boomers getting more and more into Medicare and the lack of reimbursement on that. It's just going to push us more and more to figure out how to work together for the betterment of our communities and quit the whole isolationism kind of kingdom fifing, and how do we cross lines and work together for what's best for the patients. And I think Teledigm does that, tries to bridge that gap between provider groups and specialties to bring services together in one.
We've appreciated expanding services. It makes it easy when we understand Madonna's model to expand into other areas, and we've enjoyed working with the physician specialists there and the physiatrists. We actually learn. We had it.
Oh yeah.
We've tied in with the quality meetings that Madonna has in place. We've learned a lot about the reason behind the excellent care that's delivered at Madonna. Is there's a foundation to that, and so we've attended those meetings, and we understand the relevance of our care to their needs and their quality, and that's helped us as we've modeled care on the physiatry side and worked with the physiatrists. So it's always gratifying to hear that the care that we're offering meets their needs and also is helping them establish a quality of life that's going to create longevity in their careers.
Yeah, I think one of the things that, we bring to the table too is access to specialists. And so let's talk a little bit about maybe some of the specialist things advantages we can bring to a facility like Madonna, and maybe some of the outcomes there.
Yeah. So I kudos to Teledigm for being able to first put that together to get the specialists, to get them connected so that Madonna or other places have the ability to have that connection. So, great example, we are working on ways to take on more high critical care patients.
Mm-hmm.
It's the wave of where things are going because hospitals are getting more patients coming in than what, especially here in the Lincoln market, than what they can take on.
Yeah.
So we have to find a way to speed up the process to get people through the system and get them to Madonna or other sites. And one way to do that is the Madonnas and others in the world are going to have to figure out ways to take some more of these sick patients than what they've done before in the past.
Yeah.
And so, just a great example, just recently been trying to work with Dr. Bossert and your team about how could we bring on subspecialists to help provide some of those services in the after hours or even day hours for that
Mhm.
matter, to help provide that some of that critical care. So pulmonology, cardiac services, you name it.
Yep.
Where we can have those services available, but not necessarily have to have them on site 24/7 because of the cost.
Yeah.
And so that's just one example of many that we've been working with on trying to get subspecialists or have subspecialists at Madonna.
When you think about the care that's provided by a subspecialist in a facility where it's one patient here or another patient there, I think of the term transactional friction and just how difficult that is. So you have a patient who either is going to need to be transferred from a facility to another facility that requires staff and time, energy, and cost, or you have providers or physicians who need to pull themselves away from clinic or acute care in a hospital and travel across town, or in some cases, so longer distances, to then provide care for one patient or another patient. All of that super expensive, super time intensive. And honestly, I don't know that we have the labor force when you talk about clinical expertise that can actually accomplish that anymore.
Right.
We have shortages in so many different disciplines. So that can all be overcome with access to virtual care, and it can be delivered in a timely manner and delivered when the care is needed, and it allows the expertise to remain in their comfortable arena where they're either taking care of patients in clinic or in the hospital or elsewhere. So it does allow for that. And then in terms of cost, it just builds that clinical expertise into, in this case, Madonna's circumstance, in a way that is just a fractional cost of what it would be otherwise.
Mhm.
So it really is a win-win-win where it meets everybody's needs and ultimately provides really high quality care for the patients.
Yeah. It's not just about cost savings and cost effectiveness for the facility itself. It's addressing the reality of the shortages of some of these specialties that we have, and I think that being able to craft a service like this is kind of the way things are going to have to go.
It's interesting. A lot of the demand for our services is for overnight care.
Mm-hmm.
And we are happy to meet that demand. We can gap fill wherever the gaps are needed, but we find that many locations, whether they're acute care facilities or LTACs or other facilities that we serve, it's nighttime care that is really in demand. And so we'll step in that area. We also provide a lot of daytime services, but nighttime care is where we can really, I think, help sites meet their needs. And a lot of our services at Madonna have been overnight services.
Mm-hmm. And that really speaks to the whole work-life balance. I think the reality that we've all seen is the docs coming out of med school today do not want to be 24/7 docs.
Well, I'm an old guy, Andy. So
I know.
Don't get me started on that.
I hear you.
I will say
I am too.
We have, it's just awesome. We have the healthcare in Nebraska is spectacular. UNMC and Creighton do a great job. So we have really talented folks coming out of their educational experiences there, but there's just a shortage, and so we just need to facilitate that. And telemedicine has really stepped in when the needs were great. COVID's an obvious example, but I think healthcare in general needs this. So it's worked.
And Dr. Bosser brought up a really good point. If you think about years ago when Madonna was smaller, I mean, I'm talking 30, 40 years, docs would go there and they would round and they'd see other patients at the hospital. And that was just the old style of doing it. Now with patients being more sick, more complex, they're coming through the system and going to Madonna or other sites like that, more complex. You have one patient that needs a pulmonologist or one patient needs to be reviewed by a cardiologist. That's that transactional friction he mentioned, which is so true. But now in the evenings, nights, whenever that is, if you have one from Madonna, one from someone in Omaha, one from Kentucky, one from Missouri, LTAC, pretty soon that transactional friction from the telehealth side is now a good volume of patients that one doc is seeing. And it's just gets back to, we got to figure out ways to help each other and work together and get rid of this whole competing. Let's work together. And that's a great example of doing that, because now you have this one doc that has a panel of patients, this specialist that's seen them, but they could be in 10 states. It's great.
We have a team that becomes super expert in EMRs. And so you just mentioned various locations where one physician will be covering relatively small volumes at any one location, but multiple locations. And we commit to working within the local EMR to maintain really high level of continuity, high level of communication and service. So that one doc has to be expert in multiple EMRs. We work hard at that. We have a team that helps with that onboarding and support. That's the challenge. And I don't know that a lot of other telemedicine applications will do that, where they have their providers working in many different languages is the equivalent, working in many different EMRs. We know that's important to the sites that we serve, so we make sure we build that out. And then we build our teams out at night. We have multiple teams on at night, teams out so that we identify which EMRs are serving which locations, and we make sure that our physicians are ready to go in those particular sites, depending on the EMR that they serve. But there are challenges to managing multiple sites when each site has autonomy in identifying the EMR that they want to use.
Yeah. But that's one of the things I'm really proud of our provider teams for is, I've been here long enough. I remember when we didn't do that and we started having those discussions. And it was like, can we really have our docs working in 4, 5, 6 different EMRs? And they were like, yeah, let's do it. And they want to be in the EMR because that's where all the information is. They can put the orders directly in and make sure that they're in. And it just made sense. And our docs and our mid-level providers stepped up to that challenge.
Yeah.
I mean, you get to a point if Teledigm, when they keep growing, you get globally, it'll have to be languages next then too.
Oh, well, I'm depending on AI so that whatever we say can be translated into 200 different languages.
Yeah, exactly.
Yeah. And we do have services for that. We have a service for language interpretation. So that is definitely something that we can roll out in the future.
We've plugged that into Dave, we have plugged that into our telemedicine application.
Really?
So we do have the
great.
language applications.
Yeah, it's been pretty incredible to see.
And Andy, you mentioned how it's been good for the physicians and the team to say they're plugging into the EMRs, but flip it to the other side, the end user.
Oh yeah,
extremely valuable that you're in the EMRs.
Yep.
And putting that information right into the system.
Yeah, because then when you're not doing that, you're faxing stuff back and forth. You're doing verbal orders and having to get back and then sign them later. It's so much more efficient, not only for the provider, but for the staff in the facility. And then the doc that comes on dayside has everything right there.
Right.
So, yeah, and I think we talked a little bit about work-life balance. Let's talk a little bit about some of the wins maybe we've had at night, helping providers stay home with kids. One of the benefits I think we have is we've got docs and mid-level providers. They're already up. They're happy to be there with you. So let's chat a little bit about how some of that's worked.
I'm interested to hear from Dave's standpoint just how the med staff, it sounds like they're pretty satisfied, but what if there are any specifics there? In terms of some of the requests that we've had for service, oftentimes folks reached out to us in a crisis. They've had physicians who are out because of an accident or illness, or they lose staff suddenly and unexpectedly, and it's a small staff, and it's a community that is substantially impacted by that loss. And so they reach out, and we do offer an opportunity where we can step in quickly and fill the gap as long as they need it filled, and step back out when they feel that they've met their needs in whatever way that is necessary. So we are able to offer long-term sustainable solutions for programs, and that's the foundation of what we do. But we're also excited to just offer help when help is needed. And if that's just gap filling for a short period of time, we can do that. And that supports med staff that might need to be out for a short period of time, or supports communities when staffing changes happen. But as far as specific, circumstances at Madonna for the care that we've provided, that would be interesting to hear if there's anything there.
So I don't have like specific stories per se, other than feedback that I've gotten from physiatrists, our physiatrists, as well as our hospitalists. And you have to remember too, our hospitalists, many of them came from being hospitalists in acute care settings as well. So they've come to Madonna to be physicians there, coming from a past where they had a lot of those subspecialists in the building with them.
At their elbow.
And so wanting that kind of same service line, which you expect and want for your patients there for quality care. And what's been extremely beneficial is the fact that at nights when they're able to go home and rest up and be able to get ready for the next day and be with their families and I have heard multiple times how they do not go home worried about their patient and the type of care they're going to get, because of the service that we have through Teledigm. So to me, right away, not specific like a story here and there, that alone speaks volumes, because they're not having to go home worried about what's going to happen to their patient. So that's number one. Two, just recent, the physiatrist, as I mentioned, when we made that changeover, talking to one of our medical director on the physiatry side, talked about how he's had no issues whatsoever, zero, related to that transition over to Teledigm. And now he goes, now I have the ability to get a break, be home, be with my family, and come back and recharge for the next day. And not worried about what's going to happen to my patient and the type of care. But the EMR is a big component of that too. So you hear from the hospitalist saying, then I come back into work the next day, and instead of finding the notes somewhere else or trying to find the information if and when the physicians were contacted at night for care or questions, it's already documented in the EMR. So I see that when I come in. So their workflows, their flow just continues on. It's not a break in their workflow and trying to find where do I get that information or that data. And then the same can be said with the nursing staff too, hearing from the nurses about the type of care and the ease of getting with the physicians on Teledigm to be able to get answers, questions, and taking care for the patient has been outstanding. So no specific stories, but overall conversations with docs and staff it's just been great care overall.
Yeah. And I think, you talk about the physiatrist team that can rest and recharge. That's a huge quality component in and of itself. They're coming back in the next day, not wiped out from multiple calls overnight, but they're coming in. They've got the rest they need. They've got some of the downtime. They've got time with family, and they're ready to roll again.
Yeah.
So,
And the hospitalists on the same side too. They're able to get out, get rested up, come back the next day. And those are the physicians that came from the acute care side. And so
mhm.
to me, if they're satisfied with that type of service they're getting, they're familiar with it being in house. And so that has been a good win from that perspective, that they're comfortable with the service and care they're getting.
I think a, a point should be made regarding how we work through the teams that support each facility. So when we build our teams out, we identify a small pool that will provide coverage at any
Mhm.
particular location. That's important for relationships. It's important for understanding the needs of each location. It's important for understanding, what the clinical circumstances are. What Madonna will ask us to do from a clinical standpoint is different than what a small critical access hospital would ask us to do from a
Right.
clinical standpoint. So we need a team that's familiar with what the patients need at Madonna, and familiar with the staff at Madonna, and familiar with just the time issues that Madonna faces in terms of managing these patients. So we build out that model that allows for development of relationships, high level of communication, and ultimately, again, the goal is to create an environment that leads to satisfaction that I think you've described there. If we had a pool of 50 physicians and providers offering care for those units, I'm certain that the stories would be different. The stories would include interactions that are not satisfying, needs that are not being met, poor level of service. There's just something about knowing who you're working with, knowing their families a little bit, getting to know more about them than just the clinical issue that they're calling about, that makes the whole interaction better. So we build out those small pools. There's a challenge there that we create by doing that, but we think the positives far outweigh the negatives.
Oh, absolutely. I've heard that from other facilities. You talk to the nurses, and they see our providers as an extension of their team, and they get, like you said, they get to know them. There's a personal connection there. The nurse has got to call somebody, and they realize, oh, it's Dr. Schweitzer's on tonight. That's great. We really like her. And so it is a game changer, and we're not dealing with a huge pool of faceless providers that they've never met before.
Also makes a difference on the credentialing side. Payer credentialing is a huge task. It's expensive for sites to do payer credentialing. And if they are credentialing 100 of our providers because we have a pool that's large, that's that large, just makes for a monumental task for credentialing. So
Almost
we can,
impossible.
kind of help with that process.
Yeah,
I'd say one thing that Dr. Bossard, the first thing he said when he was going through that component of his talk was relationship. That's the very first thing he said. And to me, that is so powerful. And I saw that in spades. I remember when I first started at Madonna, it had to have been 3 months in, if that. And I've known Dr. Bossard for a number of years. And through working at Bryan and other things out, through work and families and stuff. But what was interesting is in one of the first meetings I had, we had a meeting with Dr. Bossard and some of the docs at Madonna, and he knew the physicians. And it caught me because I thought, being in the world I was in acute care, I didn't know if he had known the physicians at Madonna or anything. Oh yeah, he knew them and they knew him. And I saw that relationship. And in today's world, in today's healthcare environment, I think, in my opinion, that some of that relationship building and has worn down because of payers, because of reimbursement, because of competition, you name it. The relationships and trust aren't there as great.
Yeah.
But that is something Teledigm, that small panel you start with, and is so powerful and so important. And I saw that in spades. And I think that you're exactly right. That's why they trust. They go home. They don't worry because they trust and they have that relationship. And they know if there is an issue, we know who to call.
Right.
We know exactly who to call and say there was an issue.
Mm-hmm.
How do we get it resolved? How do we fix it? And you guys are on it right away.
Yeah.
And the physicians know that too. They call right up to the provider even because they may know the provider.
Mm-hmm.
Yeah.
So it's so powerful in today's world. If any of you out there listening haven't worked with Teledigm, if you get to work with them, relationship building is a key component of what you guys do, and that's so powerful.
We find that the relationships with the physicians are important. Relationships with the nurses, more important even. We
Mm-hmm.
have a clinical integration team with skilled nursing leaders who've been, in the business for 40 years and have interacted in many different levels with patient care, whether it's life flight, ICU, ER, who are part of the implementation process for any service that we offer, and then also create that access for communication if there are issues. They know that they can call the clinical integration team if there are any problems. Nursing staff is so important to the care that we provide in any circumstance, and meeting the needs of the nursing staff is a priority for us.
Yeah, absolutely. And I think that's one of the things that, Rachel and Ashley and Melissa and Maggie have done over the time is really help the nurses feel comfortable. And, you think about a critical access hospital where we're bringing in pulmonary or acute neuro, and they're going to start keeping some sicker patients. It's really important that the nurses understand we've got your back.
Mm-hmm.
We're here to support you. We're going to make sure this seamlessly integrates into your workflows. And I think that's just another key to the success of building the relationship and keeping that service high quality.
And I'd also throw in there too, Andy, from an administrator standpoint, when we went live with the physiatrists of the after hours of Teledigm, it was so simplified because I know you guys will take the bull by the horns and come out and work with the physiatrists and do the detail work with them to figure out how to make it happen. And you don't have to worry about it from the administrative side. It just happened. It was just great.
Yep. Yeah. So I think, from a critical access hospital where, we're keeping more complex patients there to a place like Madonna where you already have a lot of complex patients, and now we're helping you keep even more complex patients. I think that's really, really been satisfying for me to see. What about the future of long-term and rehabilitation care? What's coming down the road, and where do you see telemedicine fitting in that world?
Well, I see the telemedicine fitting in that world quite a bit. Like everywhere else, the payers are wanting to cut reimbursement or pay less for this, so we're having to figure out ways to pivot and transition as that transition occurs. I think the demand for the services are there. They're going to become even more intense as the baby boomers age. Dr. Bosser would know this better than I would, but I think the prevalence of stroke in younger people was becoming more prevalent. Why? Don't know for sure. Maybe Dr. Boston has the secret.
It's probably too many of these.
Too many of those monster
too many
drinks.
Of these monster drinks, like I'm addicted to.
But that's more prevalent. So the rehab post-acute is going to be so important to be able to continue the quality of life people are going to want to have, and rightfully so they should have.
Yeah.
Is if we have the services, let's provide it for them. But if that continues down the path and the growth of that and the complexity of that, it just adds to the complexity of needing more subspecialists and physicians at a time when there's less to be part of it. So that's where Teledigm fits into it. I'd also throw out the second one, and maybe you guys will think I'm all wet behind the ears, but some point, some of this will also be at home. And so does that ever factor into the future and ambitions of Teledigm or folks to be able to be almost like a doc at home even for folks? Those are the things that, as we look towards the future, what's that going to look like?
Virtual urgent care has been a thing now for over a decade, and I think has provided access to great care for simple healthcare needs, does not replace face-to-face interaction for more challenging healthcare issues. Care at home has also been a thing, more so during COVID, with some changes in what was required for a visit. That was able to, that was allowed. And I think that will only continue to expand as we identify systems to meet the needs of patients while they're receiving care at home. Our model, we've intentionally created a model that allows us to assure high quality interaction with the patients we care for each and every time. And that model, when we're working in rural communities, includes having those patients seen in that rural community clinic, hospital clinic, evaluated by the nurse, onboarded by the nurse into the clinic, so that we can see the patient then in conjunction with the staff that there is there in the hospital. It's really served our needs to meet all of the clinical issues that we see in either the outpatient arena or inpatient acute care arena. Care at home for primary care interactions and sort of continuity of care and chronic care makes perfect sense. And I think you're right, that'll continue to expand.
Well, anything else we haven't covered that you guys want to throw out here on the table?
I would just say that the services that Madonna offers to the community of Lincoln, and I've been here providing care for almost 40 years, is unique. And patients travel here from around the country to receive the care that's offered at Madonna. We're thankful that Madonna is here and has maintained high quality standards to continue to meet the needs of patients. And we're just privileged to be a part of that and excited to work with your team of specialists and clinical providers to meet the needs of these patients, because there isn't a Madonna in every in every town, in every circumstance. Very specialized care, and we just feel privileged to be a part of that.
Absolutely.
Thank you, Dr. Boster. And I would just say, being at Madonna for just this year, it's the fourth largest rehab hospital in the country. So it's not, if you're listening to this from somewhere else, it's not a small facility. And just knowing that and thinking of that, 2 locations, Omaha and Lincoln, and the services provided by Teledigm have been outstanding. And knowing Dr. Bossard and this team for 20 some plus years, first on the acute care side and now on the Madonna side, post-acute care, it has been, they're all about relationships, and they're all about quality of care and all about service. And it has been a great partnership at Madonna with them. I had a father who was a surgeon, cardiac surgeon, and he used to always say to me, 2 things you need to provide: great service and great quality, and then the money will come. Just provide a great service and great quality. That's exactly what you guys do. And I don't think you don't harbor on the money side, and that on the administrator, you think about that some. You don't. You provide a great service and great quality, and I just love it. And the relationship has been really good. And so anyone that is out there that hasn't entertained the idea of going to Teledyne or interested in it, I'd highly recommend you get in touch with them and talk further about the services that they can provide for you, because it is great service and great quality.
Yeah, I appreciate that, Dave, because I've been in Nebraska maybe 21 years next month, and 18 or so of that in healthcare. And in my time in healthcare, I've just seen Madonna as really the standard in long term and post acute care. And can't say enough good things about it. And it's really, I think it's a privilege for us to partner with you guys, because it's just been a great partnership, and it's great to partner with somebody who's got that much concern and care for quality. So I appreciate you guys coming in, spending some time with us, talking about long-term care, post-acute, and the ways that telemedicine and Teledigm Health have been able to help you guys continue to do the great job you're doing.
Thank you.
Yeah.
Appreciate it.
Thanks, Andy.
Yeah.
Thanks, Dr. Bosser.
Yep. Thank you, Dave.
We would like to thank you for joining us today. Our promise to you, the listener, you will be inspired or at a minimum find value in the information shared in this podcast. Please offer a comment or offer feedback so that we can improve this podcast and better meet your needs. Please remember to share this podcast with others that you feel may get value out of this by listening. And it's always helpful to subscribe to the podcast channel so that you're aware of future episodes and releases. In addition, if there is a rural health topic you would like to have covered on this podcast, please leave us a comment, or you can send an email to pulse@teledigmhealth.com. That's pulse@teledigmhealth.com. For more information or general inquiries, please visit teledigmhealth.com.